Well, hello, everybody. Welcome to the final grand rounds of the year. I'm Natasha Emerson, and I have the honor and privilege of introducing Alyssa Garr, who will be talking to you today. So Alyssa Garr, besides being my wonderful trainee, is a pre-doctoral psychology intern in the pediatric consultation liaison track at UCLA. She completed her undergraduate degree at the University of Wisconsin-Madison, where she first developed research interests in pediatric psychology and family systems. After graduation, she worked as a research coordinator at the University of Minnesota before starting her doctoral program at the PGSP Stanford Consortium. Her research within the Stress, Resilience, Emotion, and Mood Lab at Stanford has focused on investigating the impact of caregiver stress on illness in youth with cancer. Clinically, she is particularly passionate about working with medically ill children and their families to help navigate diagnosis, illness, and recovery. Personally, she is a joy to be with, and you can often find her around the hospital making friends with anyone from the janitor to the attending, or lurking in some staircases trying to avoid elevators at all costs. She is really a joy and really passionate about the work that she does here. So we're thrilled she's staying for a postdoc. And without further ado, I will let her take it away.
Wonderful. Thank you so much, Dr. Emerson. I am going to go ahead and figure out how to share my slides here. But while I'm doing that, I'm very honored to be the last grand rounds here of the season. I did want to acknowledge the hard work that both Rima and Ernie have put into all of the presentations this season, and just wanted to make sure that I gave a shout out and thanks to them before I start. So bear with me while I try to figure out how to make sure I share my screen here. Let's see. Okay. Dr. Emerson,
That looks good. Take it away.
All right. Well, again, thank you all so much for being here. I will be talking about, as you can see on the screen, the impact of parental stress on parent-child communication in families of youth diagnosed with cancer. This is going to be an overview of my dissertation study. However, I did try to, for this presentation and grand rounds purposes, I am keeping it more high level and talking more about the big picture concepts and clinical indications in future directions, and less going into all the statistical intricacies of my dissertation. So if you have more questions about the statistical aspects of things, please feel free to reach out to me, but I wanted to keep it more high level for this presentation. This dissertation and project has been something that's been really important to me and something that I'm very passionate about. So I'm excited to be able to share it all with you. A few things: I do not have any disclosures, and then you can submit any questions through the Q&A, and I'll answer them at the end of the presentation with Dr. Emerson's assistance. So I want to start by acknowledging the lab that I worked in graduate school. It's called the STREAM Lab at Stanford University. It stands for the Stress, Resilience, Emotion, and Mood Lab, with my wonderful PI, Dr. Victoria Cosgrove. The lab does incredible work, specifically within the pediatric cancer realm, and they continue to do the research that I will be talking about today, and have been such an important part of my career and journey thus far. Additionally, before I start my presentation, something that I just want to acknowledge is that my dissertation, as well as the research that I did, is dedicated to all the patients and families that I've interfaced with throughout my training, specifically in the pediatric oncology realm. Just want to highlight their resilience, strength, and bravery, which have been incredibly inspiring, and wanted to, thank them for letting me be a part of their care. In terms of the roadmap for today's presentation, I'll start out by providing some general background on parental traumatic stress and parent-child communication, including a few theoretical frameworks supporting the study, discuss a bit about the aims and hypotheses that I had in my dissertation, describe briefly the methods and results, and then discuss more about clinical implications, hoping that we can do a case discussion where I'll ask you to put a few things in the chat, and then some major takeaways from the work. All right, so background. So globally, around 400,000 children are diagnosed with cancer each year. And what we know is that a childhood cancer diagnosis is markedly stressful for the child as well as their family. And during this time, parents and caregivers tend to transition suddenly from a parental caregiver to also being a medical caregiver. During this time, parents are absorbing new information, managing their child's symptoms, navigating possible financial hardship, and handling school and work disruptions. So many things going on, and simultaneously managing their own emotions following the diagnosis, as well as on top of that, providing emotional support to their child and the rest of their family. And as you can imagine, this impacts the family dynamics and relationships, creating distress for the child and the family system. So research has shown that parents may experience high levels of traumatic stress following their child's cancer diagnosis. And what we know is with increased stress and also relatively few resources in the field, the kind of premise for this study is that looking into that relationship between that increased parental caregiver stress and how this impacts parent-child communication in families of youth diagnosed with cancer. That's my most intricate slide, by the way. I was very proud of this slide. All right, so when a child receives a distressing medical diagnosis or is going through medical treatment, like I said, it impacts not only the child themselves, but also the family members and the relationships within the family. So importantly, past research has shown that during these high stress times, the positive adjustment of a child may be influenced by the ability of the family and caregivers' adjustment to those stressors. So this indicates that the parent-child interaction and family functioning are essential factors that directly impact the child's potential physical and mental well-being. So that being said, it's incredibly important to understand the child's experience through the system that they're a part of. So starting with the kind of nuclear family system. And with that greater understanding, hopefully it would create a more holistic understanding of the factors that affect the child throughout their illness. So one of the theories that I'm going to talk about today is Bronfenbrenner's social ecological framework. So like I said, cancer is not just a health matter, it also strains family relationships and profoundly disrupts the stability of everyday routines within the family system. And family-centered perspectives have emerged in the field, and they see families as interdependent, self-regulating systems where each member influences the other members. So these multiple reciprocal influences have been studied using a developmental approach and have been influenced by the lens of the Bronfenbrenner's ecological systems theory. So this model aims at improving the understanding of the processes that influence human development by showing how a child's qualities and characteristics are impacted by their external environment that they interact with, and then how that influences the child. So this model has kind of 5 nested interactive systems surrounding the child. So the child sits at the center of the model, and kind of moving out from there, We have the interpersonal level, which includes the child's interactions with close people, such as their family members, their classmates, their teachers, their caregivers. We have the organizational level, including the relations within their microsystem. So that could be the family, the school, the hospital setting. We have the community level, which is the relationships with the wider social system that the child is embedded in, and any social factors influencing that interaction. And then we have the sociocultural level, which represents the cultural values, customs, and laws that govern the child's immediate context. And then lastly, we have the large time level, which is the change in consistency and characteristics in both the child and the child's environment. And why this theory is very important in this context is when disruptive life events occur, like a diagnosis of pediatric cancer, it greatly impacts the interactions of these different nested systems. And family members, part of the closest system to the child, play a crucial member in the change and helping the child potentially cope to the disruptive life event. So understanding the child's experience through the system that they're a part of is extremely important. And so this is really focusing more on that first kind of interpersonal system that the child is a part of, and hopefully wanting more of a holistic understanding of the child throughout their illness. So stress in pediatric cancer. So like I said, the diagnosis of childhood cancer is one of the most intense, disruptive, and really enduring experiences that a child, but also caregiver, can have. And cancer is often unexpected and can be life-threatening, and includes invasive medical treatments. And as you can imagine, that very much interferes with the family's normal activities and routines, and can for a long period of time, and also can impose stressors varying in duration, predictability, and then impact on the family system. So a growing body of research has actually suggested that the impact of childhood cancer on parents and caregivers can be conceptualized in terms of trauma-related symptoms or post-traumatic stress symptoms. So learning that a child has a life-threatening disease is a qualifying event for post-traumatic stress disorder or post-traumatic stress symptoms. So when we think about post-traumatic stress symptoms, we have symptoms and they can fall into acute stress disorder and post-traumatic stress disorder. And acute stress disorder is experienced in the first month after a traumatic event versus post-traumatic stress disorder, which symptoms have lasted longer than a month. And both of these diagnoses include symptoms of re-experiencing avoidance, negative cognitions and thoughts and mood, and changes in arousal and reactivity. So in terms of pediatric cancer, the specific requirement of acute stress disorder, PTSD, may not fit the reactions of the child or family to medical events. However, it's so important to look at stress reactions on a continuum and really looking at the key symptoms that are coming up for each family. So the current study really tried to get a better understanding of parental and caregiver stress in the context of the child's cancer diagnosis, which I'll talk more about. So how stress presents in pediatric cancer. So limited research has been conducted on stress in parents following the child's cancer diagnosis. However, as I've said multiple times, it is known that parents experience a high level of stress during the child's illness. So a review that focused on psychological adjustment and coping of parents of children with cancer, seen here on the slide, done by Grudenhusen last in 1997, found that increased distress, anxiety, or depression in parents of children in newly diagnosed families of kids with newly diagnosed cancer. And that research has shown that stress from a child's cancer diagnosis can lead to parents and caregivers experiencing ongoing post-traumatic stress symptoms. And it's been highlighted that early intervention with these parents experiencing acute stress disorder may allow for the prevention of it becoming more chronic. So that kind of newly diagnosed area or time frame could actually suggest that might be a phase that is incredibly important to have more support. So the acute stress after a child's cancer diagnosis. So research has shown that parents report that the time immediately after their child's cancer diagnosis is the most difficult period in their experience of their child's cancer. Further research supports this finding, again, reporting that parental symptoms of post-traumatic stress, anxiety, and depression were most severe at diagnosis. Also, research has shown that a caregiver of a child with cancer may have actually more maladaptive adjustment outcomes than actually even the child themselves, which I find incredibly interesting. Children have been found to have kind of a range of responses to diagnosis of cancer, showing difficulties socially, emotionally, academically, following the diagnosis, and can kind of range from a lot of different reactions to the diagnosis itself. So importantly, what we know is that potentially the relationship between the parent and child is a key determinant of how the child responds to stress, with parental distress often correlating to measurements of distress in the child. So in families experiencing pediatric cancer, research has shown that connected and communicative families can promote healthy adjustment, protecting against distress for both children and parents. All right, so we're going to talk more about understanding the parent-child communication dynamic in pediatric cancer. So communication itself, right? Communication is a big word. It is generally understood that communication is a crucial component of interpersonal relationships, no matter what context you're speaking of. And, others kind of posit that communication is considered to be a central component of all human interaction. So communication can really enable parents and children to provide support and share information with one another, which is incredibly important. So in the current study, communication was conceptualized and measured using Barnes and Olson's definition of open communication and problems in communication. So open communication, defined as unconstrained and free exchange of emotional and factual information, and then problematic communication, diminished interactions, caution with depth and breadth of sharing, and reluctance to exchange information. And in the context of pediatric cancer, effective communication can be particularly difficult given the stress of the situation and the medical uncertainty that comes with the diagnosis. So when we think about the importance of parent-child communication in childhood cancer, we can kind of think about how it might work in adult care. So in adult care, medical providers often treat adults one-on-one. So they provide care and they consult directly with the patient, communicating medical information and relying on the patient for medical adherence. However, in pediatric patients, this can differ significantly, with caregivers really playing a major role in communication, adherence, and care. And historically, doctors often recommended that back in the day, that parents withhold information about their child's cancer, presuming that added stress would outweigh any benefit of the openness of communication. However, over time, the views have shifted towards openness and honesty, and with most providers encouraging caregivers to inform children and their family about the serious illness that the child is experiencing. Okay, so with all of that said, studies of pediatric medical patients and their families have highlighted that both decreased positive communication and increased negative communication are associated with increased stress among patients and their families. All right, so let's talk a little bit more, and this is also important clinically, of potential challenges and barriers to open and honest communication in pediatric cancer. So, through the research that I've done and also clinically, there's different things that come up in terms of the challenges and barriers. So it has been noted that sometimes caregivers find it difficult to communicate with their children in pediatric cancer because they're wanting to protect their child from the distress. This comes up a lot. This is something that we would see very frequently, especially on CL. Kind of similar to that, right? Caregivers, avoiding burdening their child with difficult information, that their child is also, sick in the hospital, that they don't want to provide, further stress on their child, which is understandable, of course. And then, additionally, a lack of confidence in caregivers of how to communicate health information. That kind of dynamic that I talked about earlier of, all of a sudden they become a caregiver to also being a medical caregiver, and all of this new information and really being at the forefront of not only for the child, but for the parent to digest themselves. So not sure how to communicate the diagnosis itself, which we're going to talk more later with a case example. Then we also think about parental mental health. So research has shown that high levels of stress, depression, PTSD can reduce the amount of communication between parents and children about the child's illness itself. So that can be a huge barrier. And then, also considering the child's current mental and physical capability. How severe, how acute is the patient presenting currently? And then lastly, the fear of loss. The fear that, by saying it out loud, that confirming the diagnosis, that, that this could worsen or lead to negative outcomes. Okay. So it's also important to think about the factors that impact parent-child communication, within not only the child, but the family system. So when communicating to a child about a chronic illness, the child's age may impact how much information a parent decides to discuss with their child, of course. So there was a study by Coyne et al. That reported that parents communicate more openly with older children. And it was identified that actually children younger than 9 years old receive less information about their medical condition, treatment, and diagnosis, forming difficulty, a barrier for a parent communicating to their child about the diagnosis. And since many pediatric cancers are diagnosed at a very young age, children may be too young to comprehend their cancer diagnosis or treatment. So parents have this, and caregivers have this really difficult role of determining what information they share with their child, how they can share it in a developmentally appropriate way. And this can be incredibly challenging. This is something that, again, we'll talk about in a case example soon, but I want you to all start thinking about how would you communicate a cancer diagnosis to a child under 9 years old? What language would you use? How would you discuss it? These are very difficult things and hard things to think about. Additionally, there's cultural differences that come into play with communication in cancer, in pediatric cancer. So research has shown that some cultures carry a stigma around the word cancer, which can impact how information about the child's cancer diagnosis may be communicated and reported. And that parental disclosure of a child's cancer diagnosis to their child varied significantly across cultures. Additionally, which I spoke a little bit about earlier, is disease severity and prognosis have shown to really impact the parent-child communication, with poor prognosis and disease severity shown to have decreased communication between the parent and the child. So the one thing that I really want to highlight is across multiple cultures and studies, two themes really emerged as common factors in parents choosing not to disclose a diagnosis. And one was the desire to protect the child, and two is the general avoidance of discussing the difficult topic itself. So that brings us to the current study. So the current study really looked at the relationship between parental stress and parent-child communication in pediatric cancer. It also aimed to explore the nature of parent-child communication and child resiliency. It looked at factors that also may impact the parent-child communication, such as child age, ethnicity, disease severity, and gender. The project was a cross-sectional design and was part of a larger project within the Stanford lab that I had discussed earlier. Okay, so this is where I'm going to briefly discuss my dissertation in terms of time, because I really do want to make sure we have time to discuss the case study. I'm going to briefly discuss my dissertation. However, I'm more than happy for anyone to email me to further discuss the methods, the results of my specific study as well. So the aims and hypotheses that I had in my study, right, like I said, one was to investigate the relationship between parental stress and parent-child communication following a pediatric cancer diagnosis. And I hypothesized that youth whose parents reported high levels of traumatic stress would report a lower degree of openness in communication, and youth whose parents reported a high level of traumatic stress would report more problems in communication. And then the second aim was to investigate whether aspects of parent-child communication promoted resilience in a child diagnosed with cancer. So I hypothesized that youth whose parents reported a higher degree of openness in communication would report a higher level of resiliency, and then youth whose parents reported more problems in communication would report a lower level of resiliency. And like I said, the exploratory aims were then to also study how age, ethnicity, gender, and length of time since cancer diagnosis impacted the parent-child communication following the pediatric cancer diagnosis. All right, so briefly going to go into the methods. So like I said, this was a study that was part of the STREAM lab at Stanford, the Stress Responsivity, Emotion, and Mood lab. And the eligibility criteria for the study was for parents, they needed to have a child with a cancer diagnosis. We had a lack of resources of different languages, so they needed to be fluent in English. They needed to consent to the research. The parent had to be older than 18 years old, and their child had to assent to the study. And then the eligibility criteria for the child was the child needed to have a cancer diagnosis, needed to be fluent in English, assented to participate, and that the parent was also enrolled in the study. Briefly, the procedures. So, recruitment through different modalities, but mostly through the Bass Center for Childhood Cancers and Blood Diseases at Lucille Packard Children's Hospital. Participants were informed about the study by staff members at the Bass Center who were familiar with the lab and projects, and then shared contact information. We also did recruitment there. So we would contact families to inform them of the study, and then would conduct the consent and assent. We did quantitative data collection through REDCap and self-report measures, and they would fill out the measures as well as measures from the larger study. All right, so participants. So overall, ended up having 62 parent participants who signed consent and completed demographics forms and parent questionnaires. And notably, 94% of the parents who filled out the questionnaires identified themselves as the participant's mother. So a high level of female mother participants. In terms of measures that I used, so I had a demographic questionnaire where the parent or primary caregiver were asked to answer questions related to demographics about themselves and the family, so age, ethnicity, gender, child age, gender, sexuality, cancer diagnosis, date of cancer diagnosis, things of that nature. I then used the PCL5, the PTSD checklist for DSM-5, which is a 20-item self-report measure that rates the severity of PTSD symptoms. I used the parent-child or parent-adolescent communication scale by Barnes and Olson, which is a 20-item 5-point Likert scale self-report measure that where parents and adolescents would respond to items separately regarding parent-child communication. And the measure had the two subscales that I talked about previously, which were the openness in communication and the problems in communication. I then also used the CD risk, which is the Connor-Davidson resilience scale, which is a 25-item self-report questionnaire measuring resilience. The scale has 5 domains: personal competence, tolerance of negative affect, secure relationships, control, and spiritual influences. The child measures, so the child had to be 10 years of age or older to answer the questionnaires. They filled out the parent-adolescent communication scale and the Connor-Davidson resilience scale. All right, so I'm going to go a bit into the results, but I'm really not going to dig too far in because I want to make sure that we have more of the clinical implications to discuss. And as I said, please feel free to reach out to me if you're interested in hearing more. But really quick, we're going to look at some of the demographics of the participants that responded to the study. So child age of when they filled out the forms really ranged. The mean was about 10 years old and ranged from about 3 years old to 18. Child gender, so 59% female, 39% male, 2% non-binary. Parent gender, like I said, 94% identified as female caregivers, 6% male. Here was the child racial ethnicity identity identified by parents. So some variety, but majority white. We have types of cancer, so you can see that it varied all over the board, with leukemia being 38%, brain tumor 20%, bone cancer 10%, lymphoma 11%, and then 21% identifying as other. Okay, so in terms of quickly some of the results that I had, so even though with like the past research and the strong, really thinking that there was going to be a relationship between those things, I actually found no significant relationship between youth whose parents report high levels of traumatic stress and reporting low openness in communication. And then additionally, no significant relationship between youth whose parents report high levels of traumatic stress will report more problems in communication. This can happen in dissertations, but I'll talk a little bit more. The kind of second aim, again, with the hypothesis of youth whose parents report higher degree of openness in communication will report higher levels of resiliency. Again, no significant relationship found. And then additionally, the second aim, hypothesis of youth whose parents report more problems in communication will report lower levels of resiliency. Again, I found no significant relationship. So one of the statistically significant relationships that I did find was between child age and parent openness of communication. So this indicated that there was a positive relationship between child age and parent openness. So the older the child, the more open the parent communication. Okay. So like I said, even though past research has shown that parental distress may hamper the parent's ability to provide clear explanations and convey support to their child in the context of their child's cancer diagnosis, right? My dissertation, the current study, did not replicate the expected results, such that higher levels of parental stress would be associated with more communication challenges and less openness in communication. And I'll take some time to discuss that and why that might have happened. So something to consider is that the current study may have not measured parental traumatic stress symptoms optimally. And what I mean by that is studies have shown that there's great variety in how parental stress is measured and conceptualized, as well as when parental stress level is assessed. So the current study used the PCL-5, like I said, and the PCL-5 measures diagnostic symptoms related to PTSD and doesn't necessarily reflect an overall measure of parental stress. So given that, and also the cross-sectional design of the study, where stress level and PTSD symptoms present differently at different stages of diagnosis and treatment. And the range of assessment times in the study may have impacted the results. So parents and patients were filling out the study at different time points throughout the child's diagnosis. So results potentially may have looked differently if I was looking more at the timing since diagnosis or different considerations to make. So further study might focus on specific times since diagnosis, like in that potential acute phase. Additionally, the study used self-report measure, and communication is actually overwhelmingly assessed through self-report measures, but this actually might have complications related to social desirability and difficulties recalling communication. So self-report, like I said, was used. So in the future, it might be more accurate for it to get direct observation of communication. And then additionally, it's important to consider that some families may have high levels of openness of communication about most topics, but are not able potentially to communicate or convey medical or diagnostic information. So the specific measure that I use, the PACS, asks about openness and communication in general, not specifically related to the diagnosis itself. In terms of resiliency in family systems, so the study expected to find that youth whose parents reported a higher degree of openness in communication and lower problems in communication would report higher levels of resiliency. And like I said, the study did not find a statistically significant relationship between these. But I think it's important to think about what resiliency looks like, how it's reflected at different points throughout the patient's cancer treatment and survivorship. And it's notable that there's really a lack of research focusing on resilience within the family system itself. So I think that this could absolutely be a future direction to look further into. Study limitations, so, of my dissertation, sample size, absolutely, the cross-sectional design, nature of the study that I used, self-report measures. And then, as I had mentioned before, the lack of diversity of caregivers in terms of gender. It was mostly female, ethnicity, and then, the importance of including non-English speaking participants in research. Okay, so I want to make sure, I'm just looking at the time here. I want to make sure that we discuss the case study because I would love to hear some of your thoughts. But quickly, effective family communication has been shown to be associated with positive health, emotional, and developmental outcomes, resulting in reduced distress and actually increased medical adherence. And psychosocial support for children with cancer and their families is recommended to assist families with short and long-term adjustment to changes in their child's illness. However, it's not well known what type of care is provided within the hospital systems to families psychosocially, the frequency or the outcomes. And there's multiple different clinical implications to consider. Like I said earlier, the child and family system, it's important to view holistically, and how that, can be integrated into, potential interventions moving forward. And, the current study, right, showed that there's a relationship between child age and parent openness and communication. And this might indicate that it might be useful to think about the clinical importance of integrating developmental friendly approaches to communicating cancer diagnoses, which we're going to talk about in a second with the case example. Why don't we actually go ahead and do that? Okay, so bridging clinical work and research. Okay, so I'm actually going to open the chat because I'm going to have people respond in the chat. And I know we have about 5 minutes before we'll do questions, but I would like to think through this. So this is a case that I saw on CL, and this was a 5-year-old Latina female with no previous medical conditions. And she was brought into the hospital by her parents with significant leg pain and swelling. And throughout her hospital trajectory, she was initially put in a leg cast, and they weren't really sure what was going on with her leg. And it took, weeks to figure out, what exactly is going on, and eventually landed with a cancer diagnosis. And with this cancer diagnosis, the parents had, of course, high parental distress related to the diagnosis, had difficulty adjusting to the hospital setting, and they were really hopeful that even though they received the diagnosis, that they were still hopeful that maybe it wasn't cancer. And so when we were consulted on CL, the patient was selectively mute. They appeared depressed and anxious, and the patient was unwilling to walk, even though they were able to walk, but they were unwilling to use their leg. And the medical team had shared the diagnosis with the family and the child, and that's what we had known so far. Okay, so my question for everyone is, put yourself in the mind of a caregiver during this time, like what language would you use? How would you communicate to a 5-year-old that they have cancer? Like what specific language do you think you could use for a child to understand such a diagnosis? And I know that's a big question and we don't need to get all into it, but I think it's important for you to at least consider, the nature of being able to describe that to a child. So I'll have you consider that.
Feel free to put it in the Q&A or the chat, and I can read them out.
And while we're kind of waiting for those, I'll kind of say that, eventually what happened with this case is that even though the diagnosis was explained to the child, that when I eventually asked the patient why she thought she was in the hospital, she had believed she had a broken leg. That's why she thought that she was receiving all this care and she was in the hospital for multiple weeks, is she thought that her leg was broken. And which is also why she wouldn't walk, because she initially had come in with a lot of leg pain, and that's what she had understood. And so this really shows the importance of really helping families and caregivers and medical caregivers to be able to really assist with difficult conversations, and how this can really impact long-term care and medical adherence within the hospital. Really considering using developmentally friendly language to communicate with families and patients. Natasha, I don't know if anyone put anything in the chat. It's a big question.
Not yet, but I mean, I'll take a stab at it. I mean, I think I have a 5-year-old and I also work in this domain, but I'm still struggling to come up with a way that I think I would explain it. And I think just thinking about it is quite emotional. If you know, I think I would, what strikes me is not only how you're giving the information, but also that it may need to be given at multiple times. Just thinking about this patient, that like clearly the information was given, but you know, the mind processes over time. And so that she may have needed like a refresher of what, you know, her illness versus her symptoms. I think I would use terms like, you have this sickness, and it's a sickness that usually means that the doctors need to pay special attention to you. So you may need to stay in the hospital so that we can give you the best care that you can, that you deserve. And mommy will be with you, or daddy, or we'll switch off. Yeah, I think that's kind of what I'm coming up with.
Yeah, thank you. No, I think it's really important. And like, I think my main point was really having people consider that it's incredibly difficult to be able to communicate. And then when you add on the level of stress that's associated in these moments, and really taking in all these factors, and then how it can impact the trajectory moving forward.
Yeah, and we have another participant who's chiming in. Thank you, Cynthia, that suggesting that sometimes it might be nice to supplement with books that are age appropriate. So finding books about pediatric cancer, or other resources.
That's a perfect segue. So I wanted to highlight, you know, a few resources and interventions that actually exist. So one is the Surviving Cancer Competently Intervention Program for newly diagnosed families, which was by Ann Kazak in 2005. And it's a manualized 3-session intervention for caregivers and children that they do there. This is just bringing awareness that, you know, there are interventions that are starting to really focus on this exact kind of discrepancy between, right, helping parents and children communicate during really difficult times. And then, you know, the Healthcare Toolbox is an amazing resource that provides, you know, guidance for both caregivers, medical caregivers in the system, as well as parents, and really has a lot of great information to help discuss these things with parents, children, and families. Books, so exactly where I was going. These are some really amazing books for caregivers after a child's trauma, and can be really helpful, especially with pediatric cancer. And then additionally, here there's some amazing websites that have a lot of more information and some great resources that I'm happy to share. But I know we're at our over our 10-minute mark, so I will go ahead and stop sharing here. As you can tell, I really enjoy talking about this, so I knew I was going to go over, but I'm happy to answer questions.
Thank you so much, Alyssa. It was really, really great. Really good refresher, but also really illuminating. We have one question. Thank you, Dr. McCracken. So one of our, Dr. McCracken's question is, first of all, he says, great talk. Did your analyses take into account the differing rates of quote unquote curability across all cancers? So I think that is a good question. How does the individual prognosis of the type of cancer you think might that have affected your outcomes?
Yeah, at my personal dissertation did not. However, that has been something that has been looked at throughout multiple different research studies, and it really shows that the disease severity is a major not impact on how the parent-child communication dynamic, but also can be a huge barrier to communication, especially if you know, the child isn't able to absorb the information because they are so incredibly medically ill, or again, that kind of parents not wanting to further burden their child. And so that is absolutely something that is incredibly important to consider, and moving forward, I think would be an additional study to factor to add in.
Thank you. Yeah, no, it makes a lot of sense. We have another question here. Hi, Patty. Patty asks, did you find that parent level of stress correlated with the child's level of stress?
So in my study, unfortunately, no, there was no significant correlations. However, it has, how I kind of brought up earlier in the presentation is, yes, it has been shown and replicated through multiple research studies that, yes, a parental stress is highly correlated with child stress. And that has been shown throughout multiple studies. I think, like I said, with my study, and I'm very open to continuing to talk about like my specific study and like the things in
Oh,
no, it's okay, no worries. Of my study and why that may be. But yes, over time, that has been something that has been replicated.
yeah. Oh, relatedly, I was actually kind of wondering, because I know, of course, your study was focusing on the parent-child communication, but I was wondering if you'd found anything in the literature about general social support for parents and how that affects outcomes, specifically considering some of our patients who are in really strict isolation protocols, meaning that parents, can't be seeking support from their friends, from their families, can't be distracting children in play the way that they would normally.
Yeah, that's such a great point. And actually someone in my lab looked at that exact question. So yes, it has been looked at of the social support of caregivers and how that has impacted not necessarily like the parent-child communication dynamic, but parental stress in general. And interestingly enough, there's been studies also looking at COVID and how during the time of COVID with these really families with kids that are extremely medically ill and their lack of social support, and how that had skyrocketed parental traumatic stress. So I think it's something that we're still seeing the aftermath of these families that during these times have been extremely socially isolated, and how we've seen that the impact of that as well.
Yeah, it makes a lot of sense. Absolutely. The other question that came up was, I know this was a cross-sectional study, obviously, so you were able to, and you mentioned that one of the limitations was that you caught them at different times, but oftentimes we start off with one prognosis and then things change over the course of treatment. Did you find anything related to the fact that when a prognosis changes, like that, so the change in the parent and child communication, when it goes from perhaps quite hopeful to less hopeful? I'm just wondering if there's actually data on, out there on how that second discussion is held, and whether that impacts adjustment.
Yeah, that's incredibly interesting. From what I've looked into, I haven't seen where they kind of are able to really quantify that in terms of like, when different, because I feel like in the cancer trajectory, there's so much ups and downs, but I think that that's something that would be incredibly interesting to look further into, is right, and it's kind of related to Dr. McCracken's question of, how does prognosis really impact throughout time, the parental stress and also the communication, and how can we capture these certain time points. So I think it's something that would be really interesting to look more into, that my study did not. Yeah.
Okay, well, we might have time for one more question. If there's anybody out there, feel free to put it in the Q&A. If not, obviously I think Alyssa mentioned that you can reach out to her for those resources or for further questions, but thank you so much, Alyssa. This is so meaningful and so interesting. And despite the lack of significant findings, it's such important work, and just speaks to the complexity of everything that these families deal with.
Yeah, absolutely. And thank you all for bearing with me. I know, it's a long talk, but I really appreciate you all listening. And I want to say that, that I've learned so much from everyone's grand rounds, and that this being the last one, it's something that I really value as being part of an academic medical center. And so, yeah, thank you all so much.
Great work.
Thank you.
Thanks, everybody.